Hello, this is your video lecture on antepartum, discussing the concepts of reproduction, development, and comfort. And I will be going right along with your PowerPoint, so feel free to just come along with me. Your first slide talks about preconception age, and basically what that talks about is just that most people should go to their physician before they're thinking about getting pregnant, but really only 30% of women actually do that. And most of those women who do that are women who've already had some issues in previous pregnancies or women who have some chronic diseases such as hypertension or diabetic, or they have asthma, or they have lupus, any other type of chronic condition. The first few weeks of the pregnancy are the most critical, which sometimes people don't even know that they're pregnant. So that's why there is more spontaneous abortions that happen within those first 12 weeks because of maybe chromosomal issues or other teratogenic issues. The other thing too is high-risk pregnancies are considered high risk for people who do have some of those different conditions, as well as women who are over 35 or the adolescent. Now, again, there's always increased risk for complications when you have something already coming into a pregnancy. But then there's also pre-existing health conditions, as we had just mentioned. Keep in mind substance abuse and alcoholism and any type of environmental exposure is something else to be considered. So, pregnancy is a trying time, and we're going to talk. You're going to learn more about that as we go through the semester. Adolescent pregnancies are considered under the age of 20. 10% of pregnant people are of adolescent between the ages of 15 to 19, and of that 10%, 20% of those adolescents already have a child. So the risk is that there's a risk in decreased outcomes. Are they ready to be parents? They may be abandoned by their family. Increased risk for high school dropouts. Increased risk for neglect. The average age to have a baby is about the age of 26, which doesn't really mean a whole lot, but it's just kind of giving you a little bit of some demographics and some statistics that you can think about. Signs of pregnancy. There's three things that you have to know about. One is presumptive, one is probable, and one is positive. Presumptive are those ones that are the least reliable because they can be associated with different conditions. When we talk about amenorrhea, which is not having a menstrual period, that is due to estrogen and progesterone, and its responsibility is to maintain the endometrial lining. Preparing for implantation is its job. So what happens is every month when you shed menses, that could have been or part of the uterine endometrial lining. So when you are pregnant, that is one of the first things that happen. However, we know that amenorrhea can be associated with other conditions. Okay, sometimes women will bleed with implantation, and women mistake it for menses. So sometimes they don't even know that they're pregnant. Nausea and vomiting, like 60 to 80% of women go through this beginning around the 6th week of pregnancy. And that's caused by a combination of hormones like estrogen, HCG, and progesterone. And then your breast and skin changes start with your presumptive signs of pregnancy. They begin anywhere around the 4 to 6th week. Maybe mom will begin to feel that her breasts are tender. They may tingle. She may notice that her areola is getting a little bit darker. And some women may even notice that the pigmentation of their skin starts to darken. And that culprit here is estrogen, which increases the hormones that deal with skin pigmentation. So when we talk about probable signs of pregnancy, these are a little bit more reliable, but they're still not 100%. However, even the changes can be visualized by an examiner. The Goodell sign, the Chadwick sign, the Hagar sign are all, even a positive pregnancy test is still considered a probable sign of pregnancy. Braxton Hicks contractions are those rehearsal contractions that kind of start, okay? And they shouldn't be painful at this point, but it's just your uterus starting to prepare for that big day that's much later in the pregnancy. And then the positive sign of pregnancy is where you can actually on ultrasound see the fetus or the embryo. You hear fetal heart tones. Moms may be able to feel the baby, and fetal movements are visible to the examiner. So you have to know the kind of the differences between presumptive, probable, and positive. Okay. Getting into pregnancy development, there's 3 stages that are part of pregnancy, and it's pre-embryonic, embryonic, and then the fetal stage. Okay. Pre-embryonic is like ovulation to conception, and then embryonic like begins on day 15 up until the end of the 8th week, and that's where the baby is called an embryo. And then after 8 weeks, so 8 weeks and 1 day up to delivery, it's considered the fetal stage. So when we talk about fertilization, once the fertilized egg is fertilized, or once the egg is fertilized, it becomes a zygote containing both mom and dad's chromosomes. So the zygote goes through mitosis as it's moving through the fallopian tube, or cleavage is the other name for it. And it's what it's doing. It's making its way towards the uterus so that it can implant. As it's traveling through the fallopian tube, it starts changing into different things like a blastomere, which is has more cells. And now at this point, it's called a morula. So then the morula enters the uterus, and then it separates into layers. The outer is called the trophoblast, the inner is called the embryoblast, but together they're called the blastocysts. And that is what implants into the wall of the uterus at about day 6 to 10, okay, after fertilization. And it's implanted into the upper wall of the uterus because it's rich in blood vessels, so it's very vascular. There's a lot of oxygen, receives a lot of nutrients at that part. So once that happens, the endometrium is referred to as the decidua. And this is going to be an important term when we talk about how the uterus heals after delivery, okay? The underneath side forms the maternal side of the placenta, and then the embryoblast develops into 3 layers. And so we're going to talk about the ectoderm, the mesoderm, and the endoderm. So ecto means outer, meso means middle, and then endo is actually inner. Each of these layers develop into specific tissues, systems, and organs. And I'm not going to go into all of that. But then the amnion and the chorion develop, okay, and they differentiate. Now, the amnion is that inner layer that arises from the ectoderm and is smooth. And it creates that space between the amnio and the embryo, which is the amniotic cavity, which contains the amniotic fluid. And that's by day 10 to 12. The blastocyst at this point is now referred to as the embryo. Now, the chorion derives from the trophoblastic cells, which we now call the chorionic villi, which make up the fetal side of the placenta. While the amnion and chorion are forming, the yolk sac is also forming, and this can be seen on ultrasound at 5 weeks. Now, the embryonic stage is the most critical. So what I just talked about was more pre-embryonic. Now, the embryonic stage is the most critical task, is the formation of and development of our organs, which is now called organogenesis. It is the most vulnerable time in pregnancy due to teratogens, and spontaneous abortions happen due to more chromosomal errors. So that's why, and sometimes people don't even know that they're pregnant at this point. So the other thing is that this is the most critical time. The fetal stage is now where you're just kind of cooking, just like getting that after 8 weeks, it's considered a fetus, and then it just goes through the refinement and growth and development. One thing that we want to talk about too is, so we talk about the morula and the fertilized egg moving through the placenta into the uterus. Well, sometimes it implants elsewhere. We're going to mainly be talking about the fallopian tube, and this is what we call an ectopic pregnancy. This is a pregnancy that occurs outside of the uterus, usually in the fallopian tube, mostly in the ampulla, which is the upper 2/3 of it, but sometimes it can implant elsewhere. They're identified a couple different ways, usually like serial lab tests, which are beta HCG, which is that hormone of pregnancy. Blood is drawn, and basically what happens is that number starts to rise. Okay, but then what happens is too is that you think you're doing okay, and then all of a sudden you're going to feel like this unilateral pain. So the second means of how they can do it is through a transvaginal ultrasound. And what they can see is that they can see that there's a gestational sac by the 5th week of pregnancy, that you can really tell if you start feeling those symptoms at that time. And some of the things that happen is, the symptoms to really remember is that the pain is unilateral, and it may refer to one shoulder and bleeding. Okay, so that it could be resting on that phrenic nerve, which actually that's why you might feel some shoulder pain. And then there might be some bleeding. Now, there may not be bleeding. Now, the thing is with this is that the treatment difference depending on whether or not the fallopian tube is ruptured, or because as that sac grows, it's going to put pressure on that fallopian tube. However, they use methotrexate, which I'm sure you've heard of that in cancer patients, but it's a folic acid antagonist, and we know the importance of folic acid in pregnancy to help with neural tube defects, to prevent neural tube defects, I should say. Now, you would have to have surgery if, for example, there's any evidence of a hemorrhage or a rupture of that fallopian tube. Now, it can happen elsewhere, like I said. It can happen like in the abdomen, but like I said, I don't even know the percentage, but it's a high percentage of that happen in the fallopian tube. Risk factors, a lot of times it's like history of pelvic inflammatory disease is like a big risk for that. IUDs, if you've had a previous ectopic, things like that. Okay, so again, this is an ectopic pregnancy. It's really important that you understand amniotic fluid functions and placental functions. There's really not much that I can say more than what's on your slide, and you need to know the difference between the two. But it's really important that amniotic fluid is so important. And as we go through the semester, I want you to remember about amniotic fluid functions because it has a lot to do with how someone's going to handle labor. Okay, so one of the things we want to talk about is that it does maintain temperature regulation, so it's the right temperature for this baby. It allows freedom of movement. It provides cushion for that cord. It is a barrier to infection. It's like one of what our body does to keep a pregnancy viable is pretty amazing. It actually keeps the embryo from getting tangled in the membranes and facilitating growth. So when people break their water early, there's issues with that because it doesn't facilitate growth. It doesn't facilitate movement. Okay. We're going to talk about too much fluid, too little fluid, normal fluid, and you're not going to be tested on that, but it's important to understand about oligohydramnios, which is low fluid. The old term was called polyhydramnios, or now the new term is hydramnios, and that means too much fluid. Okay. Now, when you have oligo, too little fluid, there could be some renal abnormalities with the baby. Mom could have broken her water, or there could have been some uteroplacental insufficiency. There's many reasons on why that could happen. Now, if you have too much fluid, there could be some swallowing issues with the baby because the baby actually kind of swallows its own amniotic fluid. Diabetes, if you have more than one baby, could be an issue. Some chromosomal abnormalities or like some fetal malformations, and that's what I was talking about. Maybe there's some GI issues where the baby is unable to swallow, or there could be some renal things because maybe the baby's not peeing, and that is another way how amniotic fluid is formed. The umbilical cord forms from the fetal side of the placenta, and it serves as the means of blood and nutrients going between the fetus or embryo and the placenta. You'll see the cord's kind of cushy or jelly-like, and it's called Wharton's jelly, and that surrounds those blood vessels and protects the cord from compression. So, could you imagine if it wasn't there, the blood vessels would just collapse. So, it's there to protect that cord. 2 arteries, 1 vein. That's what we had talked about this in newborn, where the arteries carry the deoxygenated blood and the veins carry the oxygenated blood, which is the opposite of ours. Okay. I'm going to end this first lecture on just the introduction to antepartum, and we will move forward with physiological adaptations next.